Hello, everyone. Good afternoon, and welcome to today's Geriatrics ECHO clinic. So great to have so many of you joining us. A few familiar faces, I think, out there. So just to hit the top of the hour, we'll wait a couple more minutes, give people a chance to join us. So we'll get going here today with introductions first. So back here, Troy Jorgensen, Program Manager, Project ECHO Nevada.
Mordechai Levy, UNR Med Geriatrician.
Kelly McCamillan, I'm a social worker and I'm the Associate Director of Community and Social Services at the Sanford Center for Aging, UNR School of Medicine.
I'm Umanga Sharma, I'm a UNR geriatrician.
And then we'll go around the audience here. So Patty, part of our hub team here as well. So Patty, go ahead.
Hi, Patty Swagger from the Sanford Center for Aging.
Hi, Leslie Baker. I'm the geriatric pharmacist at the Sanford Center for Aging.
Thanks. And is it Linda Petershansky from Las Vegas?
Yes, Linda Petershansky from Las Vegas, retired, and I'm very aware of what Sean was talking about that I also agree. One doctor's label governing.
Okay, thanks, Linda. Then next, it's actually the meeting code for today is the screen name 684-551-843. I'm going to take you off mute. Can you hear us? Could you introduce yourself?
She's back on mute.
Yeah, you might have to click and accept the unmute. Okay, I think we'll move on here. Rainbow Connect CGH.
Hi, my name is Ross B. I always attend the meeting for the Dementia, and I have a group home in Las Vegas. Thank you.
Thanks. Good to have you back today. Michelle Dye, go ahead.
Michelle Dye. I'm a social worker in Las Vegas.
Thanks, Michelle. And then Dr. Patricia Ellis is joined. I don't think we have audio, though, for you. So then Sean McGivney, go ahead.
Yeah, I'm Sean McGivney. I'm here on the end.
All right, and where do you work, Sean? Can you remind us?
Yeah, I work for myself. I'm a self-employed person.
Okay.
Mm-hmm.
Thank you. And then Kelly.
Yes, my name is Kelly, and I work for the home health agency in Reno, Nevada.
Great, thanks for joining us. And last is Cam D. Cam. Could you introduce yourself? Just a second while I get you off mute there. Yep, go ahead. We should be able to hear you. Okay, maybe no audio there. So we'll open it up. Does anybody have any specific patient cases they want to talk about with the panel right now? Or any other questions that they'd like to bring up? Feel free to unmute yourself with the icon in the lower left corner of the Zoom window or write in through the chat box.
This is Dr. McGivney for the record. I have a question. It actually kind of overlaps with that whole dementia labeling thing and some of these new well-intended dementia-friendly Nevada and all of those. Is there any risk, and I'll just pose this to the group, of misusing that well-intentioned thing to actually label people unnecessarily? Like, does being labeled with dementia when we really don't have a lot of understanding what it means, there's no good treatments, and there are treatments, but I wouldn't call them good treatments. Is there a potential we run by using that label too much ethically?
I'll take a stab at that. So I understand which, I have a concern when we use the word dementia, because I think there are varying degrees of folks where they may be in a continuum around cognitive impairment. I think it really becomes important to be really clear about assessment, screening, et cetera, before even having someone with a diagnosis of dementia. The dementia-friendly model, though, really is to help the community understand what it means when people have cognitive impairment and how they can interact with them, that folks may have some form of cognitive impairment, can still be engaged in the community and their personal life, et cetera. And the goal is to really help to make it more humanistic, if you would, around how we deal with it. Part of it is also helping maybe first responders understand that there's a particular way that they might need to work with folks who have a cognitive impairment. The behavior is not necessarily because they're psychotic or mentally ill, et cetera, but they're having some problems around understanding things, expressing themselves, et cetera. So I think the intent of the dementia-friendly movement is very positive. And to your point, I think there can be a little bit overemphasis of just the word dementia. I think it's much more around how do we deal with folks who experience any level of cognitive impairment. So I hope that helps.
Yeah, that helps. I'll just add in the reason for me that any of these labels are bad is because it separates mental illness from just people who are having a UTI and confusion versus dementia. Is it disease or whatever? When all of those people, including the mental illness people, need the same sensitivities that the dementia people need. So by our singling them out and they're getting more or less, then I'm concerned that the mental illness and all the other people who need the same level of sensitivity and TLC for the first responders could be somehow getting less. And I realize it's not an exact sum, zero-sum game, but that's just a concern I have. And I don't think we'll be able to fix it today.
I'm sure we won't. But we'll certainly take a look at how do we deal with situations when we're concerned about people's well-being. And there's some question about their cognitive impairment to some degree. So great discussion.
Okay. And we'll be open for questions or comments throughout the session, so feel free to unmute yourself or write in through the chat box. So we'll get going here with the presentation.
All right. Well, again, welcome to everyone. And we've been doing a series around best practices in dementia care. And again, we've used that label. But we're really talking about a wide range of topics, which have included polypharmacy, delirium, dementia, and capacity, and recognizing that it is a multifocal sort of issue. As we've already talked about, there may be multiple factors that may negatively impact people's cognitive impairment. And through good screening, assessment, and intervention, I think older adults can be treated with respect and dignity. And as practitioners, I think we can help to have older adults maintain the best level of autonomy and self-determination. And at the same time recognize that they may need some protective services. So I'm going to discuss some ethical dilemmas that professionals may encounter, especially around the issues around self-determination and autonomy. Bear with me here, I gotta advance my slides here. So today I want to talk about some ways to kind of do some screening in terms of how do we evaluate when I'm experiencing an ethical dilemma or problem. And once I am recognizing that, what can I do to sort of address it in a very consistent way? In addition, we'll take a little bit of time through a case example talking about autonomy versus protection, and I think that's always a challenge for practitioners in the field, wanting to do the best thing for those people that they see. And fundamentally, I really believe it's important for us as practitioners to identify those people who are resources to us when we're dealing with an ethical dilemma of any type. Because as each of you probably know in your own practice, sometimes it feels like a great burden, and I think in many ways it is, but recognizing that there might be resources, and we'll talk about that as well. One of the things I want to say is that I really want to take time to share information, and like I said, we'll deal with one ethical dilemma, and after we do that, there may be other situations that you would like to discuss. In preparation, one of the things I want to be really clear is I'm not going to teach you ethics. ethics are what we learn in the field and how to balance our decision-making, our collaboration with patients, colleagues, etc. So ethics basically are those kinds of behaviors that we identify as good, right, the proper thing to do. We may think about them as moral duty and obligation in some sort of way. And when we think about ethics, we may think about what we call personal ethics, those kinds of things that we do or how we live in our personal life. And then we may have particular professional codes of ethics. And I think most professional organizations have a code of ethics. They are not uniform across professions, and that's okay as well. The one thing I think is important is that for us as individuals, I would like to think that our personal ethics really coincide with our professional ethics, so that we don't have our own sort of internal ethical dilemmas to deal with. And my experience is that most professionals are committed to the work they do because they want to do good with other people and make lives better for others. And also, ethics or codes of ethics are not legal mandates. They're not legislated. They're endorsed by our professions. We're asked to subscribe or commit to that code of ethics. Now, there may be, quote, ethical dilemmas wherein we have to take a look at laws and mandates, etc. The thing that comes to my mind quickly is that as professionals, we're mandated reporters when we identify a child or a vulnerable adult who might be the victim of abuse, neglect, exploitation. So in that particular case, I think that's where the ethics coincide with some legal mandates. And the other thing that I think becomes really important to understand is that codes of ethics don't necessarily tell us what to do or how to behave per se in a very clear-cut way. They actually provide guidance for us. So on the one hand, that's can be a little bit of a conundrum when you're dealing with a specific situation. So keep in mind that what we do is based on our values, what we do as professionals, and our ethics are then those values in action. And so an ethical dilemma is any circumstance when there's a conflict between two or more values that are from our code of ethics or maybe even our personal values. For me as a social worker, it might be that issue around client self-determination and right to confidentiality. Or it might be right, their self-determination versus protection. And so those kinds of things then create the particular dilemma. So again, when we talk about, or I'm talking about ethical dilemmas, it might be some ethical dilemma you experience between a conflict around particular values. How do I respond to a situation? Or it might be a dilemma between you and another colleague. Maybe you disagree about a treatment approach or intervention. It also could be between you and one of your patients. One of the more complicated ones that we see in our geriatric clinic is when we, as a professional team, have a particular set of values that we subscribe to, the patient has a different set, and the family has a third set. That becomes a little bit more complicated, but nonetheless, those are the things that do occur for us. And ethical dilemmas typically may occur around treatment decisions, treatment recommendations, etc. And some of the things I want to talk a little bit about today are really about how we deal with those older adults living in community settings, because there's a different set of conflicts or dilemmas that we face. So I'm going to talk about a couple of pieces that actually we've discussed before, but I think it's valuable to sort of review. So I want to talk about what we call capacity. And here it's really meaning the clinician's opinion of a person's ability to make decisions or perform certain functions. And again, this is where your skill and expertise comes in. And it's much different than the broad removal of human rights associated with competency or guardianship. So keep in mind that capacity is really specific to a task. It may fluctuate over time. And so that when you as a professional are saying the person lacks capacity today, it may be because of that urinary tract infection or the cause of maybe some medications that are affecting their cognition. And then the other piece that becomes important around capacity is how does it relate to the decision, the social environment, the particular things that are occurring for the individual. And again, that's where some of the issues around risk and ethical dilemmas comes into play. So again, keep in mind, people's capacity may fluctuate over time. And in some research around capacity, they find that it's even unimpaired adults, their ability to comprehend and remember things may be somewhat limited. So again, it's that caution that when we encounter somebody, we may not see them at their best moment. And it may take time, it may require us to really have some more dialogue with them and take the time. And again, it goes back to that point I think you made earlier, Sean, about not jumping quickly to a decision about dementia, et cetera. I just want to quickly reference the Nevada Revised Statute. It refers to people as being incapacitated and then requiring guardianship. And the condition is usually the individual is unable to meet essential requirements for physical health, safety, and self-care without appropriate assistance. And I just mention this because from my perspective, and I think you all would agree, is that going to guardianship is the last thing we want to do for anybody because it really compromises their civil rights as human beings, et cetera. And it, like I said, I think it's just a really very, if you would, strong-armed approach to deal with things. And sometimes folks still refer to guardianship. I encounter this with families, say, we need to guardianship. And it's like, well, let's find the least restrictive way to go first. So I think as you work with individuals and where this ties into capacity and where it ties into any sort of cognitive impairment is, what is the ability of the individual to express any form of a choice? And most of this language really is about, say, medical treatment, but I think it can cut across into some community living sort of pieces as well. What is their ability to understand information relative to any kind of treatment decision or recommendation that you're making? And how are they able to sort of appreciate the significance of the information in their own situation? And I think this many times is sort of the challenge as we talk to folks in our clinic about our recommendations. Many times they may sort of minimize, it's like, oh, it's not a big deal, et cetera. And it really requires us to take more time to help them recognize what are risks for them if they do this and don't do that, et cetera. Again, like I said, all this does require conversation with them. And what is their ability to engage in a sort of logical process to weigh treatment options? My experience has been that sometimes that when we're talking about medical treatments recommendations, it can be a little bit overwhelming. People may not understand the language we're using. When we're dealing with community living or possibly issues around advanced directives, we can get at sort of what do they value, what is important to them. And those kinds of things remain pretty consistent in people's minds, regardless of any sort of degree of cognitive impairment. Again, recognize that when we're talking about consent based on recommendations for medical treatment, we have to also determine, is this an emergency situation where we have to have a decision today? And I think in community practice, that may not come up very often. Again, I'm sure there are times when you as practitioners are saying, you need to go to the hospital emergency room now, et cetera. That's different. For many community dwelling older adults, there may be some time, there's not imminent risk of harm. And so again, recognizing that this conversation about choices, your treatment recommendations for support and care may take several conversations with them. Again, in as much as possible, when you can involve family members, that's helpful. Again, it may create some more dilemma because families don't always agree with the older adults, and it's, but it is through conversation. I refer to this particular document, and when I've taught social work students, I've used this quite a bit. This is from the social work literature, and this may not be something you agree with per se, and may not fit with your particular professional code of ethics, but I think it's at least a starting point for us. And again, just want to recommend that, or mention that these are just guidelines for us. And these are principles based in highest order of protection of life down through truthfulness and full disclosure. So I think we would all agree that when we're making recommendations to older adults and patients, that we're really thinking about their health, their well-being, and at times the recommendations may really be about protection of life. Number two, the equality inequality is a little bit awkward to understand, but I'll do my best to explain it. Typically, it's around a social justice perspective, that similar people are treated the same, and people who are different are treated in a similar fashion based on their situation. Again, I'll go back to kids and adults. We have a tendency to allow adults much more freedom and autonomy in decision-making. So we ideally, hopefully, we're treating all older adults the same, that they have these abilities, autonomy, et cetera. Whereas with kids, we tend to be much more restrictive. And again, there's a role for parents, and so that might be the difference to understand this one. Autonomy and freedom is something I think we all have a lot of respect for. And again, I'm sure as a professional code, all of you really subscribe to the idea of causing the least harm. Quality of life is a phrase we use frequently. It's very broad. I don't want to say nebulous, but it's hard to define. My view of what quality of life is entirely going to be different than yours or anybody else in this room. And that's really okay. And this, again, becomes part of the conversation we have sometimes with older adults. You know, what is it that constitutes quality of life for them? And I think for them, as older adults, then when they begin to experience restrictions and how they can live, et cetera, it really has an impact on their overall view of quality of life. And sometimes it just requires a lot of help to recognize that, you know, safety is valuable as well. Privacy and confidentiality, again, is important, but not as important as autonomy or protection of life. And then truthfulness and full disclosure. For me, this is sort of a tricky one. I think it's implicit to me that we should always be truthful and fully disclose. And again, given some of the context of situations and describing situations with patients, clients, et cetera, there may be times when we don't have an opportunity in an emergency situation to fully disclose everything. It requires taking action. So these are, like I said, a particular set of principles. I don't know if anybody has any questions or comments about them, thoughts, reactions. Certainly open to that. Taking the silence as no comment, I'll move on. So then the next situation is, so I'm dealing with an ethical dilemma. Is there a particular way that I can kind of walk through this? And so this schema called ethic is one way to do it. And so basically, you know, what are the particular relevant social, personal, client, professional values that are creating a particular conflict or dilemma in some way? And then I think it is important for us to recognize what are our ethical standards from our professional, and how would we apply those to this particular situation? And again, are there relevant laws that we have to consider, or case decisions? I think for any of us in practice, case decisions probably does not come up very often. It's really probably more relevant laws and our ethical code. And then I look at this really as a problem-solving model of sorts. So what the next step is, what do we hypothesize about possible consequences of different decisions? And this, I think this is a meaty part where in working with older adults and their families, if they're involved, is talking about those various consequences. From your perspective as a professional, what are the concerns that you have, and why are they important to consider? In addition, then we also want to think about, you know, what are the benefits, what are the harms in terms of carrying out a particular process with older adults or recommendations. And then finally, consulting with, in this situation, it describes a supervisor. You may or may not have a supervisor, but you certainly have colleagues, other people that you can talk to. And depending on your particular work environment, you may not have a lot of peers around, but I do think it's valuable to think about who is a person I can reach out to talk about this. My own experience has been when I talk out loud and think things through, I get perspective. But also, my colleagues have been helpful many times, kind of saying, well, did you consider this or that? It's like, oh, did not think about that. I was so enmeshed in this particular situation, I had forgotten about that. I don't know how well this would work per se for community practitioners, but hospitals have ethics committees. Are they available to you in some size, way, shape, or form, or members of the committee? Because they really study and deal with ethical dilemmas frequently. So they may, in fact, have dealt with a situation that you're encountering, and it could be a resource to you. And again, I just want to emphasize is that we're dealing with ethical dilemmas. We're not making a judgment about somebody else's values. We're just saying that we're looking at something and we put weight on a particular value more so than the other person. And again, thinking about older adults, we're concerned about their driving and their ability to navigate quick responses, not getting lost, etc. And they're thinking about independence. And so that's where the conflict is. And it's not a judgment that we don't think they should be independent or they don't deserve that. It's like, how do we balance that in the least harmful sort of way? And so again, that's, I think, where context becomes really important.
I'll jump in on that driving one. The state, the Alzheimer's Society, or the Alzheimer's Task Force, and the Lou Ruvo Center, and some of the other dementia helpers, again, we're using the label of dementia as the main thing for a doctor to be forced to report someone to have to take a driving test. So that was, I don't know if it actually passed, but a year ago, that was one of their ways to help out and protect the senior from, having a bad outcome driving. And I'll just tell you, my experience is that seniors value that so much, they're extra cautious with or without dementia. My mother with a stroke, she never would exceed her short range so that she wouldn't lose that privilege. But I know younger kids, for example, drive and drink, drive and do marijuana all the time. And that's why their insurance rates are higher. So we just have to be careful with how we label people, and taking away their driving can be a big one. And in my view, overstepping. But anyway, enough said.
It's a huge issue. I mean, in my work with older adults, they can remember various things through their lives, but they, and there's a lot of things they do forget, but they never forget the day they got their driver's license. And they can't imagine. And again, think about yourself. Can you imagine not being able to drive? And what do you take for granted? And again, going back to the piece of restricting certain sort of functions people have will lead to other sort of issues or problems. If people can't drive, they can't get to medical appointments, they can't get to the grocery store. So again, there's a lot to consider around these issues.
I'll share one more McGivneyism. For example, in my interest of keeping all of you dementia geriatrics people safe, I'm going to insist I take away your driver's licenses, because the leading cause of death up to the age of 40 is accidents. And all of you doctors who know those life expectancy tables would know that if you're around 40, it's more common than AIDS or heart attacks, etc. So my interest at keeping you safe would be to get you to give me your keys. So obviously you're not going to do that, but that just goes to put it in perspective when they want to take away a senior's right to drive solely based on that label.
I understand what you're saying. And again, there's this whole notion of what we call dignity of risk. And again, this is the conversation in terms of, if you would, talking to people in terms of getting them to understand what are the risks they're taking. Do they really understand that? And again, to your point, it does seem pretty onerous to put it on a physician, if you would, to have to take away people's driving rights. That's not anything I think any physician relishes doing. So it's a huge issue. So I want to move on to a situation. This is not anybody I know, but we'll talk about Edith. She's a 78-year-old widow living alone in her one-story home. She's coming to see you for her visit. You're treating her for hypertension. insulin-dependent diabetes and hyperthyroidism. And she tells you with great delight that she does not forget to take her medications. However, your medical assistant reports to you that her blood pressure is elevated at her clinic visit today. Her recent labs indicate her A1C was 9.5%, so you have that information. In addition, you conducted a mini-cog, and I want to emphasize, a mini-cog is not a diagnostic tool, it's only a screening tool. And when she completed that, she was able to get her clock drawn correctly. However, she did miss 2 of the 3 words on recall. So again, it's not diagnostic, but it gives you some clue as to some concerns. So you become then concerned a little bit about her ability to manage her meds based on some of the lab values and readings you get. And then you begin to wonder a little bit, well, what else might she be experiencing as challenges living alone? And I would suspect that most older adults don't go into great detail about that. They may say, everything's just fine. That's a common sort of phrase. But you decide to go ahead and ask, is her son providing any informal support? And she reports that he is not involved at all, and she does not want to burden him with anything. That's our case. And I'm curious, from all of you out in the audience there, what do you think's going on here? What are your concerns as you read this? Please unmute and speak up.
Well, I'm concerned that I don't know that she really has insulin-dependent diabetes. If she's 70 years old and there's no other big issue with the diabetes, perhaps she could be managed off of the insulin. So we don't really, as it is, as you all know in medicine, given the revolving door of healthcare these days, the in-depth knowledge of physicians on the patients can sometimes be lacking, but there could be issues with that.
Okay, all right, good point. Other concerns or things that come to mind around this case? I'll go back a bit here. Any concerns about autonomy and freedom, least harm, quality of life? Anything that comes up?
Not from a specific ethics standpoint yet, but I'd want to kind of gather other information to give me a better understanding of her medical adherence to our recommendations. You could check a TSH too. That would also give us an idea if she was adherent to her meds. We could see how many of her appointments has she not showed up to, because obviously she showed up today, and so she has the ability to make her appointments and schedule those appointments, and then kind of again see what I would also kind of want to see what matters to her. I guess kind of going to which one of those would be quality of life, as far as what she's hoping to get out of her healthcare now that she's 78 years old.
Okay, good. As a social worker, I'm curious to know what sort of informal support does she have or not. How is the family involved in any kind of way or not? And for me, then the conflict is she's saying, I don't want to burden him. So she's not giving me permission, or you, the practitioner, any permission to engage the family. So again, it's, again, these are not huge necessary ethical dilemmas per se, but these are the sort of the beginnings of where it happens. In the next visit, as you continue to assess some things, you may decide it's important to engage the family, and there may be more pushback. It's like, no. And then it might get into the area around privacy versus confidentiality. What if her son calls and says, I'm concerned about my mom and what's going on here? So again, that puts you in a situation. It's like, what do you disclose? Do you have a signed consent, HIPAA agreement, et cetera?
Patty asked, could you do the MOCA?
You could do the MOCA. I'm going to defer to Dr.
But again, that's also one of the screening tests. It's not for diagnosis, but definitely MOCA would give us more information about her memory rather than the mini-cog. The one more thing I would add here in regards to least harm is if her, like going back to Edith, if her A1C was around 6, in the last 6 months. Now it's jumped to 9.6. If her blood pressure was well controlled on the last visit and now it's uncontrolled, and like Dr. Lavi said, if her TSS now is off the chart, which was probably pretty controlled before, then those would be the clues as regards to physicians saying that maybe she's forgetting to take the medication. And additionally, as mentioned earlier, she's on insulin. So if she's not doing it every day and she remembers to inject insulin one day and then takes a lot, then she might have a hypoglycemia that would definitely be harmful. So going back, so the concerns for me at this point would be someone providing an oversight on medications, especially insulin, and just the fact that we know she does not want to burden her son. We have to find out a right way on how to do least harm at the same time, give her autonomy and freedom. So those were the things that came to my mind.
Okay, very good. Yeah. And again, maybe she's not interested in involving her son, but she might be open to the visiting nurse to come and help with monitoring. So again, I move forward to sort of, we've taken a look at some of the particular values that come up in terms of professional codes, et cetera. We've taken a look at some possible consequences of different decisions, how to create sort of benefit and reduce harm from our perspective as well. And in this collaborative approach, I think that's the advantage here. We've had this collaborative approach to sort of talk through some of the things. There's a question.
Yeah, so we did get a comment here from Dr. Ellis. So definitely struggling with losing her independence, therefore may not be truthful in what her real needs may be at this time. Is she self-isolating from the family to hide what her real needs may be? Rights to choose, confidentiality, and she has not been deemed incompetent. Privacy, sharing her personal information without consent. Is there a safety issue at this time? More information is required to make a sound decision.
Yes, absolutely, yeah. And again, from my perspective, I think these are conversations with her, to be really frank, I think. And it may not happen in one visit. Yeah. It's like, I'm going to trust that you are taking your meds accordingly, et cetera. I'm going to see you back in a certain period of time and we'll reevaluate.
Exactly. I think that would be the best way to, set some expectations from her. What does she really want? And you're right that, she's 70, 80, she's having cognitive impairment. We might not want to manage her A1C very strictly, that's all fine, but we have to make sure, she knows what her target blood pressure, target blood sugars are, and then, we need to have maybe providing a pill box or a way to self-remind her to inject insulin would be the first thing to start for the next few months, and, we would have more idea when she comes back.
Yeah. You talked about some lab work looking at her thyroid. Is there some other contributing factors that are also impairing her cognition that day? So again, not jumping to conclusions.
Even diet, like if she's self-isolating, not eating right kind of diet, does she have access to go and get her medication? So those would be some of the barriers to consider at this time, rather than jumping on diagnosis of dementia.
Yeah. And again, as a social worker, I think some of the other pieces are talking about how to involve other providers. Maybe it is to go to the senior center to begin to be more involved, or making a referral to Aging Disability Services Division to see if they're willing to provide some support and services, do a home visit, et cetera. Because again, the challenge is you only have what she's reporting, as you pointed out. Other thoughts or recommendations about Edith?
I guess the one thing that I found always to be most helpful, again, before we kind of jump on that diagnosis of delirium, you want to rule out any delirium or acute confusion or any underlying psychiatric illness or medical condition. And then I've always found it, there's always a rare exception, but being honest with your patients as far as your concerns about their cognition, they really appreciate that usually. They don't really take it offensively as some of us might imagine. And then you are able to get a lot of that ancillary information because you guys are working as a team to ensure somebody's safe, rather than creating any sort of adversarial kind of relationship as as they feel like you're trying to do things differently because you think they have some sort of cognitive impairment.
Yes, good points. My other experience with older adults is that for them, the living independently is the huge piece around quality of life, and I get that. And typically, their concern is when you begin to ask questions about outside help, et cetera, is that they're afraid someone's going to come in and take them out of their home. The state is not invested in removing older adults from their homes. They're invested in helping them stay there. It does require some agreement and cooperation. But again, I think people may have had other experiences that were sort of unsatisfactory as they watched older adults slowly lose ability to be independent. And I think those are real concerns. And this is, again, where the conversation comes about managing their health, their well-being, and the partnership, as you described, Dr. Lavia, I think is really valuable. But reassuring them that your goal is to support them in their quality of life, their independence and autonomy as much as possible. So my hope is that, like I said, with this sort of, there, let me get the machine to, yeah, I'm trying to go back here. Yeah. This sort of hierarchy of principles, this may not be the right one for you. Develop your own, look at your own code of ethics and develop some stuff that becomes important for you and provide you some guidance around how you might rank things in terms of where the conflict exists in your action. Using this sort of guideline for ethical decision-making is another way to at least evaluate all the particular pieces that might be important in terms of decisions. And again, I just want to emphasize, there may be a sense of sort of burden responsibility as a professional how to do this, but really engage other people, engage the patient, the family, other colleagues, et cetera. Because I think, that collaborative approach, team playing really does work in an effective sort of way. And recognize that, there is this piece around dignity of risk. If an individual really does understand these are some of the risks they want to take, and you've done your job in terms of informing them of those risks and why you're concerned, I think from my perspective, I think we've carried out our professional responsibilities.
So another comment here from Dr. Ellis. Adult daycare is a great option if the client wants to be in a social environment. Speak with the client to see what she wants. To do is vital. Complete the home visit to have a true observation of the home environment will show the true quality of life the client is living.
Absolutely, yes, yeah.
Can you elaborate a little bit more on adult daycare centers?
Sure. Adult daycare centers and senior centers, I think, are really, really great options. So the senior center basically is more of a drop-in sort of environment. They exist in various communities. Usually there's a meal served. So it's going to be just a regular meal, not a special diet. But at least it provides some minimum daily requirements around food and nutrition. There's social interaction. There may be programs they put on. So it keeps people engaged. Adult daycare is much more structured. People have to apply to actually be admitted into the program. There's some consents. There's issues around payment. In Nevada, at least, let me backtrack. In Washoe County, for sure, and I know there are some other grants throughout the state, people can apply for what's called respite care. And essentially, it's a small grant of $1,000 where people can use those dollars to pay for adult daycare. There is a cost for adult daycare. People may go for a day. It's an all-day, 9 to 5. Structured environment with people. They don't provide medical care there. They may support people in terms of taking their medications, making sure they're taking them, but they don't necessarily administer the medications. But again, it's a way to be socially engaged with folks. And we know that social engagement is really good antidotes to any sort of cognitive impairment, reducing the impact of depression and isolation. So those are really good options, I think. The challenge sometimes can be for older adults is like, I don't know anybody there. I don't want to go by myself. And I understand that in many ways. And it might be, engaging the family to say, well, go with your parent and check it out yourself to be sure it's the right kind of environment. Or maybe talk to the individual and see if there's a friend or neighbor who goes to a senior center and they might go with them just to try it out. But my experience has been that once people go to a senior center, most of them enjoy it. They may not go every day, but they do find a good social outlet. Other recommendations about services for older adults? I'm curious, I have fairly thick skin. Is any of this information helpful in terms of the guidelines or the principles? Yes.
Oh, Kelly.
Yeah, Kelly, go ahead.
Oh, I was just gonna say that I think one of the, most least restrictive options for, a patient that may not be adhering to medications, whether it's they don't remember to take them, they just don't want to take them, anything like that, but they don't want to quote unquote burden their family, is, there is the option of setting up medication reminder phone calls. And they can get a medication reminder phone call as often as they need, multiple times a day. And excuse me, it's a verbal, automated service that will tell them exactly what they want them to tell them. So either, hey, Kelly, it's time to take your meds, or hey, Kelly, don't forget to check your blood sugar before you eat, your lunch. And I always believe in going from, the least restrictive to more and more support. The problem surrounding medication management is there really is no such service besides personal involvement in someone's life. I mean, the state doesn't provide that. PCAs don't provide that. As you said, more to life, adult daycare, none of that's going to provide that. So it really is on to the patient unless they have a guardian. And, then you do deal with the ethical dilemma of their right to choose. I mean, yeah, of course, we want their health to be in the best of condition. Is it that they're choosing not to take their medications, or is it that they're forgetting? Because those are two completely different things also.
Yes. Correct. Good point. And it might be, is the reason they're not taking them a financial one.
Yeah. Or just getting tired of taking a lot of medications. That's pretty common too.
Yeah.
Kelly, what resources do you use for those reminders?
It is called House Calls. And yes, I work in the Fernley, Fallon, Silver Springs area, and essentially it's just a form and you just fill it out and you fax it in, and they put in the referrals every Wednesday and they start that very next day. I mean, I just put one in yesterday, and my patient should be receiving 4 phone calls every single day starting tomorrow. It's very efficient. It works amazing. And I mean, even with this specific patient, for instance, she told me that her PT had set her up with, alarms essentially on her phone, but it got to the point that she didn't correlate what those alarms were. And, it was just a ding on her phone, and she figured out how to turn it off really quick, and she wasn't taking her meds. And I was like, okay, well, let's try this medication reminder phone call, because it will verbalize to you exactly what you want it to say. And I'll ask them, what do you want it to say? I'm not just going to put, Kelly, it's time to take your meds. Will that jog your memory? What do you exactly want it to say? And that also gives them a little bit of control in the situation too, that they feel that it's in their words of what this automated service is going to say to them. But it's called House Calls, and it does all of Northern Nevada, to my understanding.
Okay, great.
I'm just wondering if it's the same resources that Dr. Baker uses for, yes, okay. House calls. Okay.
Yeah, okay.
Yeah.
Go ahead, Leslie.
Yeah. Oh,
Yep.
go ahead.
You're
Okay.
done.
Yes, that's the same resources that I use.
Thank you.
Yeah, thank you for sharing.
Dr. Ellis with another comment here. Respite care is a must. Senior center is an excellent outlet as well here in Las Vegas, as long as the staff is trained professionally to work with the seniors. Senior companion services, where another senior is assigned to the client to go to the home, take the client on outings of her choice. Most seniors have limited income and resources. Screening the companions are a requirement to eliminate elder abuse of any form.
Yes.
Yes. We do have something
there are several different sort of senior companion type programs in Washoe County. And they all have to go through a background check that's conducted by the state. So yeah, and again, that's a key point in terms of protecting older adults from risk by companions, et cetera. So those are closely monitored. Well, great ideas. And again, appreciate the comments about various services. Because again, I think this is the kind of stuff that helps older adults maintain their independence and autonomy, even despite any slight or moderate cognitive impairment. I think with support from formal services as well as informal services, family, et cetera, folks can live quite successfully at home and don't have to be in locked units.
Yeah, and then I think we are going away from using the term dementia. Even in diagnosis, we would like to see more minor or major neurocognitive disorder mentioned rather than just the term dementias.
Should we wrap up here?
Yeah, so just, so this is just a list of my references I used for this presentation. Again, admittedly, half of them are social work resources. They're helpful to me. Your own professional organizations may have similar sort of resources in terms of how to deal with ethical dilemmas, how to assess competence, et cetera. There is good literature about that. And it is complex. And yet I think it really is an important part of good care for older adults, to treat them in the best way possible and to help them maintain their independence without any kind of diagnosis that limits them in some sort of way.
Comment from Dr. Ellis. Great. The safety and welfare of seniors is definitely a priority. Most are lonely and vulnerable. Thanks for the collaborative efforts to address senior concerns and needs daily. Any other comments or questions before we wrap up for today's session?
Everybody a little over, but it was a good discussion.
So next month, August 21st is the date for that one. So hope to see you then. Well, yeah, we'll have the Washoe County Guardians joining us. So thanks. See ya.